My name is Shilajit Kundu. I'm an associate professor in the Department of Urology in Northwestern Medicine. I also serve as the Chief of Urologic Oncology of the Robert H. Lurie Comprehensive Cancer Center. So one of the main reasons that we have a BCG shortage in the United States is that we get it from one company, and that's Merck. Sanofi used to make it in the United States, but they stopped producing BCG for use in 2016. What we're doing is in accordance with the American Urologic Association and the Society of Urologic Oncology is risk stratifying based upon low, intermediate, and high risk. The patients who still get BCG induction therapy are high-risk patients. So these are patients with high-grade T1 or CIS or both, and there are some other high-risk criteria which urologists need to be familiar with in the setting of the BCG shortage. And those patients are getting induction BCG, and they get maintenance for no more than a year. The intermediate and low-risk patients, we are no longer recommending BCG in accordance with the guidelines. What we're recommending for intermediate patients is they consider intravesical therapy, such as gemcitabine, valrubicin, or other kind of therapies that are currently being used, usually for BCG refractory disease. But in the setting of the shortage, we think that's the most reasonable options. For low-risk disease, we are recommending observation. There are many important factors that a urologist needs to consider in the setting of the shortage of the BCG. Number one, aggressive upfront surgical treatment. That means an aggressive resection with resection and/or ablation of all visible disease. Now with optical therapies such as blue light cystoscopy, we are able to reduce the risk of recurrence by really identifying more subtle disease that may not have been apparent with white light cystoscopy. There is an option, for example, to get BCG from other countries. There are other strains developed and made by other countries, but currently the FDA does not allow for usage under normal circumstances in the United States. Another option would be to consider things like intravesical therapy if they think it's appropriate based upon their risk stratification, specifically intermediate or high risk. Another more aggressive option, which is oncologically very effective, is radical cystectomy. Another option for our patients in the setting of the BCG shortage is enrolling into a clinical trial that we have open at Northwestern Medicine. That trial is called S1602, where we're testing two strains of BCG. Number one, the Tice strain made by Merck versus another strain called Tokyo 172 made in Japan. And all patients who enroll as a part of this trial with intermediate or high-risk bladder cancer that's non-muscle invasive are able to get BCG, including induction and maintenance therapy, for up to 3 years. So we really think this is an important avenue for our patients to get the BCG in the setting of the worldwide shortage, and it's very important for our patients.